Ladies and gentlemen, good afternoon. Welcome to Transitions, the Philippine launch of the reports on compulsory drug treatment and rehabilitation. This event is an initiative of the United Nations Joint Program on the Protection and Promotion of Human Rights in the Philippines. We are gathered today in person at the University of the Philippines College of Law in Quezon City, and we're also live and streaming online via the College of Law's Facebook and YouTube sites. I am Lee Garcia, and I'll be your host today. To formally start Transitions, let's all stand up for the singing of the Philippine National Anthem. Please be seated. The United Nations Joint Program for the Promotion and Protection of Human Rights in the Philippines, or the UNJPHR, is a 3-year technical cooperation and capacity building partnership between the Philippine government and the UN with a view of improving further the situation of human rights in the Philippines. We are grateful for the support of the UP College of Law in hosting today's public launch of the reports on drug policy component of the UNJPHR. To give the opening remarks, let's all welcome Dean Carlo Vistan.
Thank you very much, Lee. Commissioner Karen Gomez Dumpit of the Commission on Human Rights, General Doris Dorigo of the Dangerous Drugs Board, members of the judiciary present with us here, Judge Renato Pambid of the Regional Trial Court of Quezon City, and also a member of our faculty here in the college, and Judge Corazon Gaite Liandera of the Regional Trial Court of Cagayan de Oro City. Of course, from our principal presenters, from the UN Office on Drugs and Crime, Mr. Olivier Lermet, and all our other participants and viewers online, a pleasant afternoon to all of you. The University College of Law, the University of the Philippines College of Law and the University of the Philippines Law Center are honored to be welcoming all of you to what we call the UP Law Complex, this entire lot, the 2 buildings that you've seen, for this launch of the reports on compulsory drug treatment and rehabilitation in East and Southeast Asia that has been dubbed Transitions. For this singular opportunity of co-hosting this event, we thank the United Nations Office on Drugs and Crime and the United Nations Joint Program for the Promotion and Protection of Human Rights in the Philippines. Mr. Olivier Lermet from the UN Office on Drugs and Crime will likewise be addressing you in a few minutes because this is really their show, so to speak. The institutions I represent are merely providing the academic space for this information sharing and discussion event, well, at least for now. For those who may not be familiar with what we do here, the University of the Philippines is a public service university mandated under its charter to provide various forms of community, public, and volunteer service, as well as scholarly and technical assistance to the government, the private sector, and civil society. Our law center, this institution, on the other hand, was established for the advancement of legal scholarship and for the protection of human rights, with emphasis on the improvement of the legal system and the administration of justice. So when Lee Yarsha, who is a member of our faculty and not too long ago a student in these halls, asked us if his alma mater can host this event, we readily obliged. I told Lee then, jokingly but with a large dose of truth behind it, that to host this event is the least we can do to help out in this effort, considering that what they are advocating, the transitioning from a compulsory drug treatment and rehabilitation approach for people with drug-related problems towards voluntary, community-based approach, is very difficult on many fronts and for various reasons. Clearly, though, the realities of the long-standing and ever-evolving drug problem at the national and international levels cry out for fresh but studied perspectives and solutions, as the over-reliance on punitive responses are not providing a significant deterrent effect, to say the least. We therefore take this opportunity to provide an open, hopefully creative space where the UN Office on Drugs and Crime can help stakeholders and decision makers in considering other possibilities. The first step offered is that of confronting the facts through the reports on compulsory drug treatment and rehabilitation in our part of the globe, that will be presented shortly. Before ending this welcome address, let me express appreciation and gratitude to the following. The United Nations Philippines, under the leadership of Resident Coordinator Mr. Gustavo Gonzalez, Senior Policy Advisor Mr. Olivier Lermet, and Program Manager Ms. Sarah Toner, for the continued assistance to the Philippine government in the area of human rights-based approaches. The British Embassy, through Ambassador Laurie Bofils, who unfortunately cannot join us, for their support of the event. The UP Law Center's Institute of Human Rights, headed by Professor Elizabeth Aguiling Pangalangan, and the Institute of Government and Law Reform, headed by Professor Solomon Lumba, both for co-organizing this event. Finally, again, let me thank you all, our attendees and participants, for joining us for this launch. I wish you all a pleasant afternoon.
Thank you very much, Dean Vistan. We sincerely appreciate the support of the UP College of Law. The regional reports that we will be launching today is a joint publication of the UN Office on Drugs and Crime, or UNODC, and the Joint UN Program on HIV and AIDS, or UNAIDS. To give a message on behalf of UNODC, let's all welcome Mr. Olivier Lermet.
Dear Dean Carlo Vistan, dear Commissioner Karen Dampint, dear General Doris Dorigo, Judge Renato Pambid, Judge Corazon Gaite Landera, Ines Feria, in her capacity as expert but also as a NOVOX leader, and members from IDU Care, and UN colleagues, notably from UNAIDS and OHCHR, Sarah Toner, who's the program manager of the joint program. So, good afternoon. Before, and of course, we talk about transition, so we also have a lot of people that are joining us online, right? So we are transitioning from pure digital to hybrid and face-to-face. Before I start what I'm planning to say, I just would like to share a little bit more informally a couple of thoughts because I've got some institutional memory of that work, both at the regional level and at the country level. Why are the compulsory drug treatment centers an important issue, right? We've been engaging with the 9 countries that participated in that report. We've been trying to collect the evidence for about 10 years. We had like several rounds of consultation, one in 2010 in Bangkok, one in 2012 in Indonesia, one in 2015 here in the Philippines, and more recently another one in Bangkok. We are talking of a very conservative estimate of 500,000 people, right? So when we talk about intervention, trying to protect, as leaving no one behind, trying to protect a population that is particularly vulnerable to human rights issues, including simply the socio-economical rights, right, that are defined by the human rights and the Philippine Constitution. This is a huge number of people whose life can be changed like really drastically immediately. And when we talk about those people, we talk about their family and their communities, right? So both from a pure humane and human right point of view, public health and public security, this is a major issue. And this is unfortunately an issue that is a characteristic of Southeast Asia. That model has been the prevalent way of dealing with people who have a drug problem, or worse, people that we suspect may have a drug problem, even if they don't have a real one. The centers, I won't go into the detail, but talking in simple language, the centers are a problem because human rights violation and abuses are taking place in several countries. That has been documented, right? We've been engaging with several human rights advocates in the different countries and globally. So this is documented. Second, one of also the issues is forced labor. That we don't have that documented in the Philippines, but in several other countries, that's a major issue. That's also why we worked in the process with the International Labour Organization, right? Because when this is documented, whether in prison or in a center, there is leverage to try to address that. Why are they an issue? Because they are expensive. We are just wasting money putting people in a residential manner when there are many other ways that are cheaper. And last but not least, because overall, and sorry, I'm not mincing my words, because they don't work. Because we are putting people that have a number of determinants to drug use, drug abuse, and drug dependence, and the very setting is simply worsening their conditions. We have cases documented of people who are not using drugs in a number of countries in the Greater Mekong region, and when they get out, they are drug users, because if you are stuck in a facility with a mandatory training duration, which makes no sense, because the whole point is to assess the particular relation with the substance of an individual, many become drug users, right? And this is again documented that in many countries, the relapse rate after release is extremely high. In most countries, including the Philippines. There is research that we can share with you that we did not commission, but that is also showing that. So the idea has been to engage with countries, engage with experts, engage with civil society to try to agree together on a way to address this. Because this is easier said than done, right? Just close them. Well, how do we actually do that? How do we find an alternative model? So in 2015 here, we agreed on a regional roadmap for 49 countries. And that identified a couple of pillars that should be common to the countries. Of course, each country would have to adapt this according to legislation, cultural factors, etc., etc. But the one was to have a multi-sectoral decision-making transition committee, right? This cannot be a department of health issues only, a department of social welfare, public security. This simply won't work, right? So there is a need to plan together. The second is to work on fostering, enabling legal and policy environments. We know that in the region and in the Philippines, we have many legislative or policy aspects that are a burden to get to that health-driven approach. And of course, and this is aligned with what all the countries have agreed under the UN General Assembly Special Session on Drugs, on the drug problem. There is a need to boost the health system and particularly do that at the community level. There is no example of successful public response to drugs without a heavy investment in medical, in health, both physical and mental health and physical health, and social welfare. The good examples always have that in common, right? This is not a question of being laxist or hard on drugs. It's a question of trying to tackle the issue and to tackle it without proper psychosocial and medical support. We won't get nowhere. But what is demonstrated is when we do that, we of course improve the public health outcomes, but we do improve the public security. Good public health is good public security. This is not opposed. There is a complementary role to play. Okay? So today we are glad to be launching that report, but again, the idea is not just launching a report for the sake of launching a report. Is launching a report, having a look at it, and trying to identify how here, now, in the Philippines, we can have a concrete plan, right? Of course, this is going to be a process, right? Whatever we identify today is going to have to be developed and adapted to the particulars. So, as I understand, I'm talking a little bit too much. I will end up here and just say that as ODC, we are very glad that this is happening. We thank all the partners that are making this happen, and this is just the beginning. So, wishing you a good report launch and a good work today to try to identify your roadmap. Okay, I'm over.
Thank you, Mr. Lermay. On behalf of UNAIDS, Country Director Dr. Louis Ocampo will give his message.
Distinguished guests, ladies and gentlemen, colleagues and friends, thank you for being here today at the launch of the regional report on compulsory drug treatment and rehabilitation in East and Southeast Asia. First of all, I would like to particularly thank the Regional Expert Advisory Group, the government partners and community organizations for their contributions to produce this report. I also would like to acknowledge the excellent collaboration and partnership with UNODC on all areas of joint interest, and also the valuable leadership of the resident coordinator, Mr. Gustavo Gonzalez, for his support in cross-UN collaboration on strategic initiatives. The data that we will present today will show us that we need to do things differently. Mandatory detaining people in so-called drug treatment facilities is not effective. It also leads to grave human rights violations for the affected individuals and causes unnecessary costs for the society as a whole. The report, however, does not only provide data on compulsory facilities for people who use drugs, but also elaborates on promising alternatives that do exist. It describes various examples of voluntary community-based treatment. The challenge, though, is that these models often operate on a small scale. So it is important that these initiatives be scaled up. Let me share 4 lessons from the HIV response with you, and in my opinion, we can learn from these lessons in this context. 1, meaningful community involvement. Meaningful community involvement is key. Initiatives that involve peer-driven mentoring, education, counseling, and capacity building are essential elements for success. Within the HIV movement, we oftentimes talk about the GIPA principle. GIPA stands for Greater Involvement of People Living with HIV and is a principle that aims to realize the rights of PLHIV, not the least their right to participation in decision-making processes that affect their lives. A similar principle should apply for people who use drugs. Several case examples in the report mention the role of people with lived experience in the design, delivery, and monitoring of services. And those initiatives, just like in the HIV response, need to be adequately resourced. Number 2, criminalization of people. Yet in most countries, people with lived experience cannot participate because of structural barriers. Like with HIV, we should stop criminalizing people. Drug dependence needs to be managed as a health and not as a criminal issue. This includes the decriminalization of drug use and possession for personal use. Despite their popular appeal, criminalizing policies and punishments do not enhance public safety and security. Criminalization of drug use and possession is associated with numerous harms, including stigma and discrimination, criminal records that limit opportunities to access housing, education, and employment, high-risk drug consumption patterns, overdosing, and transmission of blood-borne diseases. 30. Stigma and discrimination. The criminalization of people does not arise from a vacuum, but finds its root causes in stigma and discrimination. It is a reality that PLHIV face every day, and this is not different for people who use drugs. Stigma and discrimination against people who use drugs are linked with decreased healthcare access and is influenced by public security approaches to drug-related issues that promote coerced rehabilitation and punishment in many Asian countries. 4th, multi-sectoral collaboration and partnerships. The HIV movement has shown us that partnerships are crucial for success. Partnerships between different key population groups, between different sectors, or between people living with HIV, governments, and scientists. If different groups work together, they can achieve results. Multi-sectoral collaboration and partnerships is also a critical requisite to facilitate policy shifts away from the punishment and towards a health-based approach to drugs. This has been essential to scaling up voluntary community-based drug treatment services. Successful initiatives have engaged with the health, social welfare, education, and law enforcement sectors among a range of stakeholders that also includes civil society and drug service providers. In conclusion, a decade ago, commitments were made, but little was done. Now it is time to do things differently. Let us remember these 4 lessons from the HIV response and finally transition away from compulsory facilities for people who use drugs to voluntary community-based treatment. And UNH stands ready to support this process. Again, maraming salamat at mabuhay tayong lahat.
Thank you very much, Dr. Ocampo. The Commission on Human Rights is an important and key partner in the implementation of the UN Joint Program on Human Rights. With us in person today is Commissioner Karen Gomez-Dumpit, who will give her message on behalf of the Commission.
Thank you very much, Lee. I'll dispense with greetings, but good afternoon to all of you. Again, this comes at a very, precious moment in the Commission's time because the 5th Commission will end on May 5. So it's only 4 working days to go for me. So I've been juggling many events. But just to say congratulations for the launch of the reports on compulsory drug treatment and rehabilitation in East and Southeast Asia. This report is indeed a milestone as it serves as a mechanism for monitoring the commitments agreed upon, as we heard, in the many years before this event, but particularly about 7 years ago in Manila, to phase out compulsory treatment and rehabilitation and to scale up implementation of voluntary community-based treatment. And those are the 2 key words and operative words I believe that we have to take to heart and mind today: voluntary and community-based. One of the concrete application of this report is to be able to inform the UN Joint Program for the promotion and protection of human rights for the Philippines to improve the human rights situation that was reported about a year and a half ago by the High Commissioner for Human Rights. And it's a sad reality that most of the violations that have been attended during this administration's governance is really anchored on the banner program of the war, their so-called war against drugs. So particularly, human rights-based approach to drugs control is part of the focus areas of the UN Joint Program. This voluntary community-based treatment is exactly what crystallizes the human rights-based approach to drugs control, because it focuses on the most vulnerable groups, the claim holders. It respects the dignity of the human person to allow them to decide for themselves, which is really the essence and objective of any human rights-based approach. It is empowerment. It also gives guidance to duty bearers, and they are not only confined to national duty bearers, but concentrates on the local, the community where all programs at the end of the day are implemented. It is also restorative, and it gives ownership to the individual and the community. It focuses on inclusion and actually enhances acceptance of alternatives to just approaching the drug problem as a law enforcement issue. So we look forward to the presentations, and I look forward to participating in the discussions so that we can enrich the transition to effective treatment and rehabilitation on the ground. Marami pong salamat sa inyong lahat.
Thank you, Commissioner Karen. Early this year, UNAIDS and UNODC published regional reports on the state of drug treatment and rehabilitation in East and Southeast Asian region. Ms. Karen Peters from UNAIDS will now give us a background on this publication.
Good afternoon, everyone. It's a pleasure and an honor to be with you today. Just a correction, I work for UNODC regional office based in Thailand. I've been asked to give a background on the history of the advocacy around compulsory drug treatment. And I'm very pleased to be able to do this. The advocacy and the technical assistance extended by the UN was to encourage and support this transition from compulsory centers toward, as has been mentioned, voluntary community-based approaches. And that started in 2010, beginning with an informal partner consultation. At this consultation, civil society members, including experts and networks of people who use drugs, gathered to share the evidence and issue recommendations for the intergovernmental meeting that was held in December of that year. The first regional consultation on compulsory centers was attended by senior government officials who who reviewed the legal, policy, and institutional environment governing national responses to drug use and dependence. Participants at that consultation noted the variation in approaches and recognized the need to take into account the local context in formulating and implementing responses, and they also agreed to convene again in Malaysia to discuss the way forward. The civil society experts requested a position statement by the UN on this matter, and the subsequent consultations resulted in the UN Joint Statement on Compulsory Drug Detention and Rehabilitation, which was issued in March 2012. Based on continued advocacy and increased awareness raising in 2010 and the release of the UN Joint Statement, the second regional consultation on compulsory centers was held in Kuala Lumpur in 2012. And this showcased Malaysia as an example of a good practice within the region for embracing outpatient treatment and harm reduction services for people who use drugs. The majority of the country delegations at this consultation also expressed willingness to move toward voluntary community-based approaches. Ladies and gentlemen, we recognize the challenges in moving toward expanded access to voluntary drug dependence and HIV services. These include, for example, contradictory laws and stigma, as mentioned by Olivier and Dr. Louis. In 2015, UNODC, UNAIDS, and UNESCAP, the Economic and Social Commission for Asia and the Pacific, led another round of consultations, starting with the informal partner consultations in Bangkok. These comprised, again, civil society and regional experts. And in 2015, we held the third regional consultation in Manila. At that time, a group of experts from the countries in the region came together to produce a discussion paper. This paper was the first to highlight elements which regional experts identified as key in approaching the transition. And it also was a good starting point for the discussions to come in the days ahead. The role of the third regional consultation in Manila was to go beyond the commitments that had been agreed upon during the first and second consultations. And the aim was to provide actionable inputs and technical tools to move policy from statements to actual transition. The report that we are launching today in the Philippines is a follow-up on these commitments that have been made to transition. In 2020, UNODC and UNAIDS formalized the operation of an expert advisory group through engaging a range of government, civil society, and academic professionals from the region to advise on and spearhead discussions to push for this transition. Incidentally, the Philippines has 2 experts sitting on that expert advisory group. The data collection process to collect information from the countries led by UNODC and UNAIDS leveraged the transitional framework that was agreed upon in 2015 and asked countries to report on the data on, in relation to that framework as a benchmark. The data will be presented soon by Dr. Stoicescu, who has been working with the regional officers in collecting and analyzing and presenting the information. I just want to end by commending the Philippines for taking up the baton to continue this important work at the national level, and to the UN colleagues in the country for supporting these efforts. Thank you.
Thank you, Ms. Peters. We now welcome our main speaker for today. Our speaker, Dr. Claudia Stoicescu, is Associate Professor of the Public Health at Monash University, Indonesia, and Research Associate at Center for Criminology at University of Oxford. She led the writing of the reports that we will be launching today. For our audience participating via Zoom, please use the Q&A function for questions you may have, which we will address during the Q&A segment for our event. For now, let's welcome Claudia.
Thank you, colleagues and distinguished guests for joining us for the launch of this report. I'm honored to join you today from nearby in Indonesia. And just sharing my screen here. As previous speakers have already pointed out, many countries in this region operate compulsory treatment where people who use drugs are detained, usually for the purpose of enforcing abstinence from drug use. Typically, this is a form of unconditional and forced custodial confinement administered with insufficient due process through criminal or administrative law. The report findings that I will present really take stock of where we are as a region in terms of progress toward achieving the commitments set out in the roadmap adopted by states in 2015 in Manila, and propose priority areas of action for moving forward on these commitments. Over the past 2 decades, the message from the United Nations, from civil society, and from other global, regional, and national experts has been clear. Compulsory treatment should not have any role, compulsory detention should not have any role in the treatment of drug dependence. Too often, and particularly in this region, punitive approaches have been seen and applied as the dominant solution to ensure public safety and security. The reality is that this approach has not succeeded. A wealth of evidence from across the world has shown that compulsory treatment is ineffective in reducing drug use or in treating drug use disorders. Compulsory detention fails to improve the health and quality of life of the people detained due to the lack of services that really address the complex factors that lead people to develop problematic drug use disorders and patterns. 2022 is a particularly special time because it marks 10 years since the 12 UN organizations released the first joint statement condemning the continued use of compulsory treatment in the region and calling on states to release detainees and place them within, allow them the option of voluntary evidence-based services. In June 2020, 13 UN organizations released a second joint statement citing concerns specifically related to COVID-19 transmission in these centers due to overcrowding. The report presented today consists of 3 booklets, the first of which is an executive summary that summarizes the findings from the other 2. Booklet 2 is the main overview of the status of compulsory treatment facilities, summarizing the data and using information provided or published by countries. We gathered these data through a questionnaire administered to health and drug control agencies. And in instances where data were not provided or were missing, we filled the gaps using published government data sets provided through official channels such as the ASEAN drug monitoring reports or government websites. And finally, booklet 3 is a discussion paper developed in consultation with a group of academic, government, and civil society experts forming the Asia Pacific Expert Advisory Group on Compulsory Facilities for People Who Use Drugs, which was formalized in 2020. And we have, as my colleague mentioned earlier, 2 experts from the Philippines in this expert group. This third booklet details case examples of promising practices from 8 countries in the region that support the expansion of voluntary alternatives. So before I talk about the findings, let me briefly spend some time outlining what makes treatment compulsory in the context of this work and in the context of this report. In the report, we outline broad parameters that are based on the 2012 UN Joint Statement to provide a starting point for assessing what we mean when we refer to compulsory treatment. A drug treatment system may be considered to have elements of compulsory elements if one or more or any of these conditions is present. They include, firstly, admitting people who use, are suspected of using or are dependent on drugs to a treatment program against their will, or not providing individuals with a choice to voluntarily consent or to refuse treatment, or not allowing persons the unconditional right to leave a program at any time without incurring punishment or other types of penalties. The next parameter refers to the process of ordering treatment and rehabilitation lacking adequate due process protections as established by the international human rights treaties. So this can include, as example, in terms of examples, detention being arbitrary, or the absence of a right to a court hearing within a reasonable period of time, the right to an appeal, or the right to legal representation, or there is an absence of independent oversight in terms of the grounds for continuing detention or the conditions of detention. Again, some of these will be present in certain countries and not in others. And finally, that conditions of treatment and rehabilitation may violate UN international standards on human rights. Some of these examples may include the absence of evidence-based drug treatment and other complementary health harm reduction and social support services as outlined in the WHO and UNODC international standards on drug use disorders, or having inadequate living conditions within these facilities that meet the highest attainable standard for physical and mental health. This is not intended to be a rigid definition because the conditions of treatment look very different across the region and even within a country, but between different centers. A key shared concern that I want to emphasize here is that people don't, in most cases, people don't really have a choice, a real choice to refuse or to appeal treatment or to leave this program, any of this particular treatment program at any time without incurring some kind of punishment. And now on to the findings. In summary, all 9 countries considered in the report implement some form of compulsory treatment. We found that the number of compulsory facilities, which is estimated at more than 800 facilities across 7 countries where data was available, has not changed substantially since 2012. We found that in 5 countries, there was either an increase or no change in the number of compulsory facilities, and only 2 countries actually registered a decrease in such facilities. A similar picture emerges when we look at the number of people in compulsory treatment. Approximately 500,000 people were enrolled in compulsory treatment annually between 2012 and 2018. During this 6-year period, the number of people detained increased regionally or within these 7 countries by about 1%. 3 countries reported a decline in the number of people in compulsory treatment. These were China, Malaysia, and Vietnam. While 4 countries, Cambodia, Laos, Philippines, and Thailand, saw an increase. People were held in compulsory facilities for varying durations across the different countries. This ranged from 3 months to 2 years in some places. And in most countries, methamphetamine was the most cited substance in relation to admission to compulsory treatment. Methamphetamine accounted for about 50 to 97% of treatment admissions in Cambodia, Indonesia, Malaysia, Philippines, and Thailand. Across the region, compulsory facilities remain largely under the authority of the criminal justice system, and are disproportionately staffed by security personnel, the military, or the police, which is really more typical of a correctional facility rather than a health service. The visual on staff composition that you see on the left, for example, shows that at least 50% of all staff in compulsory facilities in Malaysia and Cambodia were custodial staff, and only a minority were medical and substance use specialists. The UNODC and WHO standards on drug use disorders are clear that there is no need for security and policing personnel in the context of health and treatment services. And then I guide you to the right of the slide. These data point to massive overcrowding in facilities in some countries, with some centers operating at more than 400% capacity. This is a serious public health concern. We know that overcrowding in closed settings poses a serious risk of HIV, hepatitis, tuberculosis, and now, of course, COVID-19 transmission. As of 2018, only centers in China and Malaysia operated below capacity. Well, compulsory centers typically aim for a drug-free environment. So interventions provided inside them tend to be abstinence-based and are typically monitored through urine and drug testing. Often, interventions provided are limited to just forced detoxification. Generally, harm reduction interventions are lacking in the context of such treatment. These may include opioid agonist therapy, but also other pragmatic interventions like overdose prevention and management. All of the countries that answered the questionnaire stated that compulsory facilities were drug-free, but we know that it is not uncommon for people to find a way of smuggling substances into closed settings. And so due to this knowledge, making the WHO and UN comprehensive package of harm reduction interventions available can at the very least ensure the health and safety of people inside. In many contexts in the region, compulsory centers entail numerous human rights violations, as previous speakers have also pointed out. Inadequate informed consent, exposure to forced detoxification, and in some cases, documented violence, abuse, and forced labor. And more commonly, failure to provide evidence-based drug dependence treatment and health, harm reduction, and social services. All of these constitute human rights violations, including the violation of fundamental rights, such as the right to life, the right of freedom from torture or cruel, inhumane, or degrading treatment or punishment, and the right to the highest attainable standard of health without discrimination. In terms of costs associated with compulsory treatment, my colleagues did mention that a lot of money is being spent in the region on these centers. Unfortunately, we have limited data, and much of it is not published, or nor was it reported within the data that we collected across the 9 countries. But we can see we can see from what is available that countries do spend vast amounts of domestic funding that could be going toward proven evidence-based interventions, toward these ineffective forms of treatment. An independent cost-effectiveness study, as an example, showed that it cost Malaysia 2.5 times more to cover the annual cost of a person in compulsory treatment than it would have cost them to for a person to access outpatient methadone during the same period. And as you can see on the slide, countries are spending tens of millions of dollars on the operational costs of such centers in various countries where we have available data. So where do we go from here? UN organizations have developed international standards, and global experts are in consensus that what's needed instead of compulsory treatment is a comprehensive menu of voluntary, accessible, and evidence-based treatment options. This has been referred to as community-based treatment and care, and comprises, among other things, outpatient treatment and take-home medication-assisted therapy. It may also include psychosocial and counseling support, as well as access to harm reduction interventions, perhaps for those persons who are not experiencing drug use disorders, such as needle and syringe programs, safer smoking kits, and provision of naloxone to reverse opioid overdose, among many others. Also crucial and often neglected is the inclusion as part of this continuum of services that address people's welfare, economic, housing, and legal needs beyond just their drug use or HIV status. Services that really address those broader structural and social determinants of health that shape people's drug use and their drug use patterns in the first place. The model emphasizes that there is no one-size-fits-all service. Each individual with their intersectional needs should be at the center of a broad range of options, and treatment care plans should be tailored to each of those individual needs when and if a person seeks treatment free of coercion. This continuum of care should be accessible in the communities where people live, work, and use drugs. And also in the third booklet of the report, what I presented earlier also appears in the third booklet. So that this booklet, the discussion paper of the Expert Advisory Committee, also documents promising examples of alternatives to compulsory treatment in 8 countries in the region. A selection of these are pictured on the slides here. They include a program in Indonesia that's actually run by people with lived experience of drug use. They provide harm reduction equipment and conduct peer-to-peer mental health interventions, mental health support to people using crystal methamphetamine. There's also an outpatient treatment initiative at a community hospital in Laos that was used as a model for scaling up the program to 28 other hospitals in the country. And we also present case studies of partnership between the police, government authorities, and community-based organizations, providing low-threshold take-home methadone in China and Malaysia. In the Philippines, we documented the development of community-based treatment guidance and standards, and particularly the new client flow, which is providing the policy and practice pathways and structures to support an expansion of voluntary community-based options for people with drug use disorders. I believe you will hear more about this from the following presenters. But a common thread among all these examples is the acknowledgement that many people may not be able to nor desire to stop using drugs altogether. And this should not constitute a reason for punishing or for denying them access to healthcare. Unfortunately, the availability and access to these alternatives still remains insufficient. And many of these programs often start off as pilots and never get scaled up. There are many challenges that are slowing down this process, and you can read more about them in the report. But I would like to highlight a key barrier here, which is punitive sanctions arising from the criminalization of drug use and possession for personal use. And these can include mandatory urine drug testing, keeping registries of people who use drugs, so compulsory registration in a number of countries in the region, as well as various forms of police surveillance. These practices all instill fear in people using drugs. They promote stigma and discrimination, and they push people further on the margins rather than bringing them in, such that they avoid seeking health and social services due to fear of arrest or of being forced to undergo treatment. The way forward proposed in this report is captured in the Regional Framework for Action on Transition. This was initially proposed in 2015 in Manila and was updated in the present report. The framework presents a roadmap for governments to accelerate a paradigm shift from compulsory treatment to health and rights-based approaches. This framework provides recommendations across 3 areas: planning and management, fostering an enabling policy environment, and resourcing and strengthening health systems. In the report, we also discuss in more detail where countries stand in relation to the actions outlined by the transitional framework and its recommendations. But crucially, I want to emphasize that in terms of Pillar 1 on planning and management, since 2015, no countries in the region have established a national multi-sectoral committee with responsibility for the transition, nor a comprehensive action plan to coordinate actions to move this work forward. So the work that the Philippines colleagues that you are all planning today is really a milestone. I can't go through all of the recommendations under each pillar. You can find these on page 39 of booklet 3 of the report. They're also available in the executive summary. But I would like to emphasize those recommendations which were added, updated since the initial set of recommendations in 2015. An important updated proposed action is the removal of criminal penalties for the use and possession of scheduled drugs and other related offenses. Decriminalization, in this sense, would provide the greatest potential benefit for people who use drugs. It would reduce overcrowding, and it would free up resources for effective responses. The removal of criminal penalties for drug use and possession for personal use is an action promoted by the entire United Nations system and supported, as was outlined in the 2018 UN Common Position on Drugs. Other updated recommendations include applying the principle of proportionality in sentencing, prioritizing alternatives to conviction, detention, and punishment in contexts where drugs remain a criminal offense, as well as scaling up and prioritizing broader structural social welfare, economic, housing, and employment assistance to address the social determinants of health and drug use and support people in their complex and intersectional needs. The expert advisory group also recommends reallocating funding that presently supports compulsory systems toward voluntary community-based health and treatment services. In closing, the report we're launching today is a renewed call to action. We must respond with united and decisive action to immediately and permanently do away with all forms of detention, coercion, and forced drug treatment. And we must, as a matter of urgency, scale up health-based approaches that are voluntary and that have proven positive results in keeping people alive, healthy, and thriving. I'd like to thank the many individuals who contributed to the report, and I extend a very special thank you to colleagues in the Philippines for their very valuable contributions. Thank you.
Thank you very much, Dr. Stoicescu. That was a very enlightening presentation. We also have with us here in the UP College of Law a representative from the Dangerous Drugs Board, the lead drug policy-making agency in the country. Let us all welcome Director and General Doris Dorigo from DDB to talk about the context of drug treatment and rehabilitation in the Philippines.
Good afternoon to everyone, especially to the esteemed participants and viewers of this activity. Let me initially provide you with a brief backgrounder and the history of Republic Act number 9165, or the Comprehensive Dangerous Act of 2002, which repealed Republic Act number 6425, or the Dangerous Act of 1972. And thereafter, I will present the initiatives of the Philippine government towards improving the treatment programs for people who use drugs through the voluntary community-based setting. Under RA 6425, DDB leads the campaign against drug abuse and illicit trafficking in the Philippines. It was established in 1972, composed of only 9 members, 3 of whom were appointed by the President in the 6 other departments. The said law already stipulates for the rehabilitative confinement, specifically Section 30, which provides for voluntary submission of a drug dependent to confinement, treatment, and rehabilitation by the dependent himself or through his/her parent, relative, or guardian. On the other hand, RA 9165 mandates the Dangerous Drugs Board to be the policy and strategy-making body that plans and formulates programs on drug prevention and control. It is composed of 17 members with a goal to safeguard the well-being of the citizenry from the harmful effects of dangerous drugs on their physical and mental well-being. At this point, let me now walk you through at the onset of the Philippine government's campaign against illegal drugs in 2016. At that time, only less than 50 rehabilitation centers are accessible and capable of catering to only around 10,000 individuals. These rehab centers catered to mostly inpatient and only few outpatient treatment alternatives. There are no community-based programs available and no clear protocols to assess the screening of individuals. But under the current administration, much has been done. We have expanded the facility-based treatment and rehabilitation model to include general interventions, community-based treatment, and other services purposely for people who use drugs to have access to voluntary community-based treatment and services. This is particularly shown in the approved and now implemented client flow for wellness and recovery from substance use-related issues. This was mentioned a while ago by Dr. Claudia. On the part of the Dangerous Drugs Board, it has promulgated a lot of issuances in support of voluntary community treatment, which include, number 1, the adoption of the community-based drug rehabilitation models created by Regions 4A and 7 of the Department of Health, also in partnership with the Archbishop of Manila, for the community-based drug rehabilitation programs of the local government units in that regions. Another one is the adoption of the Katatagan, Kalusugan at Damayan ng Comunidad program as a community-based aftercare and reintegration model. This comes from a private organization. Likewise, we have also adopted the National Capital Region Regional Peace and Order Council resolution last year entitled A Resolution Supporting the Call to Establish Drug Abuse Treatment and Rehabilitation Center in the local government units in the National Capital Region. As an update, as of today, the Dangerous Drug Board has already extended financial support for the establishment of 42 community-based drug rehabilitation centers to various local government agencies nationwide. This is over and above the 73 existing DOH-managed and accredited residential and non-residential drug abuse treatment and rehabilitation centers, which are also accorded with the necessary support from the board. Another one is the adoption of the Department of Social Welfare and Development Yakap Bayan program, together with its implementing guidelines as a community-based aftercare and reintegration model. Another one is that the board adopted the guidelines for the oversight of general interventions and community-based drug rehab program implemented and adopted by the local government units at various levels. Another one is that the board approved the consolidated revised rules governing access to treatment and rehabilitation programs and services. In 2018, the referral system in accessing health care services for persons who use drugs was also approved and passed by the board. Likewise, the Philippine Drug Enforcement Agency's Balay Silangan guidelines for community involvement in reforming drug offenders into self-sufficient and law-abiding members of society. As of today, based on the latest report of PIDEA, we have now 345 existing Balay Silangan Reformation Centers. Also, we have approved the establishment and operation of a pilot community-based treatment drug abuse recovery facilities. This recovery clinic is a community-based drug abuse treatment and care model where admission is on a voluntary basis, not requiring court order. About treatment options, maintain confidential medical records and observe patients' rights and privacy. PWODs who are categorized as mild and moderate, drug dependent, who do not meet the severity criteria for admission to a residential center is referred to this clinic in line with the client flow for wellness and recovery promulgated by the Dangerous Drugs Board. As of now, we have 8 recovery clinics nationwide. It's reported by the Department of Health. The board also approved directing the Department of Health to review and evaluate all proposed and existing community-based treatment and rehabilitation programs of local government units and other stakeholders. Lastly, the rules governing voluntary confinement for treatment and rehabilitation of drug dependence. A shift in policy approaches to drug use and dependence away from criminalization and punishment has to be rationalized, as it is very challenging, and may I borrow what has been said by Dean Vestan a while ago, it's very difficult considering our culture and its consequences on the overall government's anti-illegal drug campaign. This move definitely requires legislative initiative. Nonetheless, the Philippine Anti-Illegal Drugs Strategy under Executive Order Number 66, which is a blueprint describing the strategies and programs to be undertaken in addressing the Philippine drug problem, is anchored on the framework which adopts a holistic and balanced approach which treats drug use and dependence as a health issue and promotes rights-based measures. In fact, all sectors of the society are now engaged in responding to drug-related issues. Meantime, we have other existing related laws that demonstrate the government's support to community-based services, some of which include the Universal Health Care Act, which provide for a community-based healthcare organization, which is an association of members of the community organized for the purpose of improving the health status of the community, which guarantees equitable access to quality and affordable healthcare goods and services. We have also the Mental Health Act, which establishes a national mental health policy for the purpose of enhancing the delivery of integrated mental health services, promoting and protecting the rights of persons utilizing psychiatric, neurologic, and psychosocial health services. And also we have the Mandanas ruling, which ensures just share of local government units from the internal revenue allotment from the national government. This is projected to increase the internal revenue allocation to local government units, and this will pave the way to the institutionalization of anti-illegal drug abuse councils and drug prevention and control programs in their respective areas of responsibility. Other than this, there are several pending bills for the amendment of the Comprehensive Dangerous Act of 2002, wherein the significant inputs of the Dangerous Drugs Board on the proposed revisions were duly submitted to Congress. The aforementioned related laws, DDB issuances, and other initiatives undertaken are testaments that reforms and various mechanisms are established and strengthened to improve treatment management and operations. Rest assured that all sectors in the Philippines are rallying to effectively address the drug problem in the country, and that investment to support the development of expertise and workforce capacity across relevant zones in the community is a continuing endeavor geared to resolve bottlenecks and scale up the implementation of voluntary community-based treatment and support services for PUDs. That ends my presentation. Thank you very much.
Thank you very much, General Dorigo, for the very enlightening presentation. It's very heartwarming to hear that the DDB supports legislative efforts towards implementing the vision for transition. The Philippine civil society is our principal partner in the implementation of the UN JPHR, as human rights-based approach prioritizes and privileges the voices of the community, and in the context of drugs, the perspectives of people whose lives include drugs. To give an intervention, let's welcome Mr. Juno Pegarido from I Do Care, an organization representing the community of people who use drugs.
Yes, good afternoon. By the way, my name is Juno, and I am I'm the vice co-chairman of I Do Care here in Cebu. I Do Care is a community-based organization. We started the year 2015, serving the drug user community, especially on injecting drug users. Okay, and we serve on health, especially on HIV and hepatitis C. However, we have also people in the community which is having a problem and legal issues, legal services. Therefore, we expanded our services for people who use drugs for their paralegal services. Okay, so that's it. We do community outreach in certain places like barangays. We partnership with barangay captains, barangay officials there, so that we could establish our outreach in certain places, and also we partnered with especially social hygiene clinic for our peers, especially who have HIV already in their treatment. So we treated tabs in DOH, and uh, yes, and we also partnered uh, with rehabilitation sites, which is a private sector, and we also expand our health services there. Uh, Thank you.
Thank you very much, Juno. Are always valuable to us. Let us now hear from a well-loved figure among drug policy reform advocates, a drug court judge from Cagayan de Oro City, Judge Corazon Gaitel Yandera. There might be some technical difficulties with Judge Azon right now. Judge Azon, are you online with us? Maybe you can turn on your camera and your audio. Perhaps we can proceed first with our next intervenor, and then if Judge Azon comes back, then we can bring her online. Let us now hear from a pioneer in harm reduction advocacy in the Philippines, Ms. Maria Ines Feria from No Box Philippines.
Good afternoon. So, the past 6 years, we have witnessed unprecedented attention given to issues related to drugs, with accompanying increase in budget, attention, policy issuances that have the right words, human rights, evidence-based, UNODC principles of treatment. There have been an increase, indeed, in the number of community-based treatment programs that do not require persons to be confined in treatment detention facilities for an extended period of time. We also have the client flow that has been mentioned, that attempts to link individuals to the right programs and services. Civil society also, working in communities where drugs are present, have begun to take a more serious interest in learning how to navigate and address and support their community partners. So all this attention is really good development. At the same time, we also pay the high price for this kind of attention. We just have to be honest. I think that's my plea for today. Let's be honest at how things really are. This is an opportunity that we have today. So we do have an increase in community-based programs, so this is good to transition. But we also have to be very careful in how we're doing things, because we are also a little bit concerned. How would I say this? We are also concerned because although there is increased attention on community-based programs into a health response, what we haven't addressed is the punitive mindset that has now been brought into the health response. And this makes it even more insidious, because under the umbrella of treatment, we do not see these hidden violations and perpetuation of the stigma. And a lot of these are driven by the almost pathological obsession with being drug-free or having drug-cleared barangays that have given people tacit permission to do all at the expense of the rights of people. People are still on the lists and continuing to be included in lists in communities. You know what's scary? It's so normalized that the question is, how do we get innocent people off from the lists? How do we delist people? And they will say, go to rehab or community-based programs. But the question that we need to ask, why do those lists exist in the first place? That's what we need to call out. As one of the community partners said, wala na bang katapusan to? They're forever branded. And this is not right. We also speak of forced treatment. Our social and political environment dictates it. We can talk till we're blue in the face about community-based programs. But if people are going for drug-free and abstinence, we will continue to violate rights of people. We force them into services that have no relevance to their lives a lot of times. Kasi oo, community, pero ganun pa rin usually, dekahon pa rin. It just happens to be in the barangay and not in a facility, no? So also a red flag here. If we're really going for human rights and health, why are we until now so antsy about harm reduction services? When it is very clear and evidence upon evidence upon evidence is already there. The best argument that I have heard, not best argument, the argument that is put forth always, kasi it's against our law. If that's the best argument you can put forward, then therefore isn't that the best argument to change the law? How does treatment look like now? The whole idea of compulsory is bone of contention. Maraming discussion doon. But again, as I said, given our environment now, of course it's compulsory. Just the fact that they're on the lists. I have to say this, even in the National Policy Agency, it does say there, in cases of compulsory confinement, the parents and relatives shall execute and submit statements and affidavits, providing information as to the drug-taking habit of alleged drug dependent. I am quoting. I am not saying this to just being honest, kasi if we're not honest at the start, how will we move forward? Nandun yan. Let's acknowledge it so we can address it. In our programs, community-based doesn't necessarily mean voluntary, I'm sorry to say. Because not only are they forced inside, there is no option to withdraw. In the community, if you try to withdraw or stop, and especially if you're on the list, you will be targeted for continuous surveillance, and ultimately, many times, for operations. And I think in the Philippines, we know what operations means. There is also no redress mechanisms, and this is driven by how we think about people who use drugs. This was a discussion in one of the meetings we had. But the thinking is, may mali palagi yung taong gumagamit ng drugs. He is always deemed at fault, so that there's no accountability in terms of the programs and services that are being provided. Let us revisit that. We also need to look at the indicators we have. The issuance we have that have been issued the past years are beautiful in words. I will admit that. In the DDB regulation, we have about quality of life as an indicator. But in reality, abstinence and being drug-free trumps quality of life. And that is why there is so much use of drug testing to try and catch, not even drug testing, surprise drug testing. Drug testing that are done in the middle of counseling sessions. Drug testing that is done in the guise of drug education. In the guise of, let's have a graduation practice kasi nakakatapos ng community-based programs. And drug testing is such that sobra siyang normalized that even in the staunchest of human rights defenders defend drug testing. Kasi there's a thinking that this is for their own good. So there's a lot of shifting that we need to do if we want to do this right. Those are just some of the examples that I'm pleading, let's do this carefully. Just because they're community-based programs, automatic yun, voluntary. Informed consent, what do? They shove a piece of paper that the person will sign and hold that person off. Let's look also at the implementation of the policies we have. We've spoken to LGU officials. They're asking for guidance, yung totoong guidance talaga. Because they know these people that they are they are engaging with, and they do want to do what's right. We have heard, but we have heard also there are pockets of opportunities. So let's build on this. We've heard Juno, they do amazing work, and you've heard it's engagement, it's partnership, it's talking about an array of options, service options, because hindi naman pare-pareho, porket gumagamit kayo, pare-pareho, hindi. Magkakaiba yung pangangailangan. And this goes back also to our training. Not simply training to fill up worksheets or instruments, assessment tools, that's not enough. We need also to figure out how do we bring compassion and human connection into these engagements. Let us not be so focused on programs and tools. Let's focus on the person. And let that person be front and center in everything. Context is important. Again, we can talk and talk and talk. And we've been talking a lot the past 6 years. No? Ma'am Doris already mentioned we have a lot of issuances. I think the key here is that how do we link them to the drug response? Because a lot still think of drug response as a separate thing. We have to look at this as a system, an integrated system. Another thing that has been brought up and cannot be emphasized enough is the removal of criminal sanctions for use and all activities related to use. This is non-negotiable. This should have been done yesterday. Because as I said, as long as it's criminalized, we can talk health and human rights, but it's just gonna be lip service. We have to work together to remove these criminal sanctions at the very soonest. Again, it's non-negotiable because until we do this, human rights violations will continue. And worse, under the blanket of treatment, we might end up institutionalizing these practices under the joint program. So we have quite a ways to go. But what keeps me optimistic is they are dedicated. In the 6 years we've worked on this, we've met a lot of dedicated good souls in government. That was really the one I have to say. And we're here to support those who are really working for what's best. I'm also optimistic because the fact that we are here today, that you all are here today, discussing this under a program of human rights, that's like, wow. In my 25 years immersed in this field, this is a first. Not only are we talking about creating a better response to drug-related concerns, but we are actually discussing it vis-a-vis respect and protection of human rights. So we now have this incredible chance to do things right this time. Let's be honest with ourselves. Let's not blow this chance. Thank you.
Thank you very much, Ines. Your insights are always valuable to us and for echoing the thoughts and heart of the civil society. At this point, let's now welcome Judge Gaitel Yandera for her intervention. Judge.
Good afternoon, distinguished guests, friends. I'm very happy and honored to be part of this conversation. And I'm happy to be back, at least virtually, in my alma mater, where I graduated about more than 30 years ago. So I can hardly recognize the room. Is that in Bocobo building? I used to be part of the UP Law Center as well. Anyway, I'm here, I guess, because I am judge of a special drugs court. Ever since I joined the judiciary in 2010, I have been assigned to a special drugs court in the city of Cagayan de Oro. So that's 12 years of being a drugs court judge. For 12 years, I have been sending people to detention centers. Day in and day out, I sign detention commitment orders. That's how big the issue of drugs is. And I can say in 12 years that this law, RA 9165, which we are implementing, has not deterred the drug problem. I am happy to see that there is this very welcome initiative of transitioning specifically from compulsory drug treatment and rehab to voluntary and community-based treatment. Actually, there is still a step before we can do that, because the major obstacle that I see before we can transition to voluntary and community-based is the existing legal and policy environment that we have. Ines has said it, and I think many of you recognize that the major obstacle that we have is actually the law. This is RA 9165. And I would point out the fact that even in the declaration of policy of RA 9165, this is very telling of the kind of policy, the kind of legal and policy environment that we have. It says it is the policy of this, the second part of the declaration of policy, it says, the government shall pursue an intensive and unrelenting campaign against the trafficking and use of dangerous drugs. So trafficking and use are mentioned in the same, the same level. It's like demonizing use of dangerous drugs. And corollary to that is Section 15, use of dangerous drugs, whereby a person who is apprehended for using dangerous drugs for the second time shall suffer the penalty of imprisonment ranging from 6 years and 1 day to 12 years and a fine ranging from 50,000 pesos to 200,000 pesos. That's criminalizing use of dangerous drugs very clearly. And it is not surprising that because of the criminalization of drug use, we also criminalize possession of minuscule amounts of drugs. Section 11, for possession of dangerous drugs, we impose the penalty of imprisonment of 12 years and 1 day to 20 years. That's almost like a lifetime. For possession of a measly amount of less than 5 grams of opium, morphine, shabu, etc., etc. Before 2017 or 2018, when the Supreme Court struck down the provision which says that you cannot enter into plea bargaining in RA 916, in cases involving RA 9165, we were sending people to jail and to life imprisonment for mere possession of, there are at least 20 years for mere possession of less than 5 grams of shabu. So I don't know how many how many I have sent. So I think last year, was it last year, Ines, or 2 years ago, I was invited to this summit on harm reduction. That was a mind-blowing event for me. One takeaway that I got from that summit is what was shared by somebody who is who introduced law enforcement assisted diversion program in Seattle. He said that the criminal justice system is the source of most profound harm or hurt for people who use drugs, and that really struck me. This forum on transition is very significant for me, as I am also personally transitioning. After 12 years of being a drugs court judge, I have decided to retire optionally soon. And I would like to say that I would like to devote my time to doing more meaningful work in addressing the drug problem, hopefully with the lens of harm reduction. So I'm really very happy to be here with you. So in closing, I'd like to say that as part of the transition, we really have to address and confront that major obstacle, which is the existing legal and policy environment. And just aside, I noticed I haven't read fully the entire report, the 3 booklets, but I noticed something which I'd like to suggest also is in gathering data or about, for example, compulsory detention, congestion of jail, etc. I think there is a need to disaggregate data. We need to acknowledge the fact that there is great disparity of data between urban centers and rural areas. So when we talk of congestion of jail, it is not, I think it's not very accurate to just mention national average, because the national average, as far as congestion of jail is concerned, is much, much lower than what we have in urban centers. For example, in Cagayan de Oro, where I'm based, the congestion rate in our jail for female is 369%. For the female dorm in just one of the city jails, the congestion rate is 264%. This means we have people in detention numbering 2,363 for a facility which can only fit 659 people. That is how worse, how bad it is. And I suppose in other areas like Manila, it could even be higher. The congestion rate could be higher. I think we need to point this out. If we need to raise the alarm and concern over the effects of criminalizing drug use. Thank you very much, and I hope to hear from the others and learn more. Thank you.
Thank you very much, Judge Ason. We are grateful for your participation even after conducting a day of court hearings. We will now proceed to the question and answer segment of our program. So the first question that was sent, this is addressed to Claudia. Claudia, a participant wants to know, do we have data on countries which are hesitant on transitioning to voluntary community-based services because of their culture? And what is the experience in promoting a voluntary community-based approach in those countries? Claudia, could you answer that question, please?
Thank you. If I understand the question correctly, it is whether we have data on countries that have refused or have explicitly endorsed compulsory treatment and not endorsed voluntary options. Is that correct?
Sure. Because of their culture, they were very hesitant to adopt the decriminalization framework. So what's the experience there in pushing for the transition?
There are a number of countries in the region where the punitive framework is certainly stronger than in others. The experiences are very different across the region. In most cases in the region, what we actually see is the coexistence of both compulsory centers and punitive legal frameworks, as well as at least the verbal commitment or desire to expanding voluntary alternatives And based on the experience of the last 12 years, we've certainly seen that this duality hasn't led to significant change. That until and as we've heard also from colleagues here, Judge Corazon and Juno and Inez, that until the legal framework can be changed, it's very difficult to expand, to really meaningfully expand truly voluntary alternatives. It is very challenging to advocate for this issue in countries that continue to support compulsory treatment. Perhaps someone from one of my colleagues from UNODC or UNAIDS may want to also comment on what the UN's experience of working with governments in this region on this issue has been.
Olivier wants to give his thoughts. You can use the microphone there, Olivier.
Hi, Claudia. I would like to nuance a little bit what she says. I mean, of course, the legal frame is a major impediment, no doubt on that, and it should be worked upon. But we also have demonstration that the legal framework reflects what the politicians are thinking, which reflects what the population is generally thinking. I'm simplifying. So if we want the population to change, to believe in change, we also need to demonstrate and pilot. We have example that the law, in fact, to have such an important change of legislation, people need to have seen already and at scale that it is working, that public security is not affected, etc. We have examples from Myanmar where the practice started a decade before, 15 years before the law was finally changed. Similarly, in Malaysia, the law was not completely changed for when the transition happened. So I feel we have to work on both aspects in parallel, right? I mean, ideally, we start with the law, but realistically, we don't wait for the law to be completely changed. We have a number of examples of that, and we have been discussing several times of the situation in Cebu, right? We have, and also just laws are also conflicting, right? We talk about the law on dangerous drugs, but what about the mental health law? What about the HIV law that should also allow some of those approaches, right? So this, I feel, is not black and white. What matters is we discuss, and we discuss honestly, as Ines was saying. Thank you.
Thank you very much, Olivier. We have also questions from the Q&A box. I invite all our panelists to answer the question by typing the answer there. But I see Judge Ason raising her hand. Judge Ason, you are recognized. Judge Ason, your audio?
Yes.
Okay.
Okay. Regarding changing the law, etc. What I see is very important is to, I see it in the reports regarding evidence-based, etc. I think we have enough evidence for, even from my perspective, I have evidence of 10 years. I would like to look at the data that I have since 2010. How many convictions, how many cases are dismissed? What is the trend in terms of cases coming in from 2010 to 2022? We have that data. How many of those, ever since we've had plea bargaining, how many people have undergone drug dependency examination? And of those who have undergone drug dependency examination, we can take a look at how many are found with severe drug dependence, how many are found with no drug problem at all, how many have mild, and how many severe. These are data that are just ready to be harvested and analyzed. And I think that is a good starting point if we want to influence policymakers and say we have the data that would back up our claim that, you know, this law needs to be changed. Thank you.
we have for the question and answer. I know that there are some more questions posted via Zoom. May I invite all the online participants to post your questions in the Facebook page of UP College of Law under the video live streaming that we're having right now, and we will aim to answer by responding to your comment in the Facebook page. At this point, we would like to recognize the United Nations Resident Coordinator, Mr. Gustavo Gonzalez, for his message and remarks on behalf of UN Philippines.
Magandang hapon sa inyo lahat. Today we are achieving an important milestone for the Philippines. The Philippines is the first country to launch the 2022 regional reports on the state of drugs treatment and rehabilitation in East and Southeast Asia. As you have heard today, the reports reflect the joint commitment of 9 countries in the East and Southeast Asia. I'm pleased to know that an important number of stakeholders from public health, justice, academia, and civil society sectors, they are behind these transitions towards a voluntary community-based approach to drugs. No doubt that today we are also charting the future of drug policy in the Philippines. As I mentioned, representatives from civil society organizations, academic partners, and government agencies, they are putting heads together to identify thematic areas for reform. And at the same time, key policymakers are deliberating the creation of a Philippine roadmap to transition from the model of compulsory drugs treatment centers towards voluntary and outpatient modalities. This process is also a first in the region, and I congratulate the Philippines for taking the pioneering step for translating evidence from our 2022 reports to immediate policy reform in the context of drugs. I hope that the reports that we have just launched serve as a stimulus for further conversation beyond this afternoon's gathering. I invite the public to read the regional reports and engage in discussions and initiatives leading to a meaningful change for the communities of people who use drugs. And I call upon our government partners to lead the process for change by making the most of a wide range of partners working in this specific sector. We know that success of this transition relies on inclusiveness. Voices of civil society are very important in policy making. On behalf of the United Nations, their partners, I fully support the Philippines in this journey. And as you know, our UN Joint Program for the Protection and Promotion of Human Rights in the Philippines is a concrete example of this commitment. And I thank our partners from the international community, especially the United Kingdom, Norway, and Australia, various government agencies, the civil society, the academia, especially the University of the Philippines, for the successful launch of the regional reports. And of course, I look forward to seeing the Philippines continue pioneering immediate reforms under a public health framework, because the objective is to improve the health and lives of the Filipino people. Thank you so much. Maraming salamat.
Thank you, Mr. Gonzalez. That concludes our event today. To our partners from the academe, civil society, and government who joined online, thank you very much. We hope that you can share the lessons and insights we have gathered from the regional reports, and we look forward to engaging with you more as we transition towards a public health approach to drug-related issues in the Philippines. Magandang hapon at maraming salamat po. For our participants in this room, For the participants in this room, we have evaluation forms in the folder.